And I also chair something called the Coventry and Warwickshire Health and Care Partnership, which is one of the integrated care systems in England. I'll say a little bit more about that towards the end because it's sort of similar to Ontario Health Teams as I understand what they are. And it might be interesting just to share some reflections on that. But mainly I'm going to draw on the work of the King's Fund, where I served as Chief Exec for 9 years until the end of last year. And very quickly, perhaps to leave time for discussion, just go through some of the work we did on this particular question. But I'm going to start with some Canadian data, as we always should on these occasions. And I'm sure you're more familiar with this than I am, but it was the Global Burden of Disease study results that showed, as in England, actually, if you look at the trends over the recent past, the good news is declining premature deaths from the major causes like heart attacks, strokes and cancers, but equally rising concerns around morbidity and disability in the population, and the relative contribution of each changing over this period of time. So as a result of the success, now morbidity, disability accounting for a bigger proportion of the overall burden of disease in Canada than was the case at the beginning of this period of time. So musculoskeletal conditions, mental and substance use disorders being the major contributors today to that burden arising out of morbidity and disability. And I'm starting here because it really provides some clues, both in Canada and the UK, as to what the current and future challenges facing our healthcare system, but our societies are, and therefore the basis why we need to change. This report that I wrote with colleagues back in 2012 at the King's Fund set out the rationale back home for a major reorientation. We called it fundamental change in the delivery of health and social care, away from just treating sickness and therefore investing hugely in our specialised and acute hospital services, to focusing much more on the challenges of the future, how we can integrate care, how we can focus on morbidity and disability and frailty too, and of course give much more attention to the prevention of ill health in the first place. I'll unpack some of that in a little bit more detail. I want to mention too the really important work of Michael Marmot and colleagues, and this is a report he produced for our last Labour government back home about 10 years ago now, Fair Society, Healthy Lives, highlighting persistent inequalities in health in our population, illustrated starkly by the fact if you get on the London Underground at Westminster Tube Station and you head out in the southeasterly direction, there's a reduction in life expectancy of 1 year for every stop on the London Underground on that particular route. So a 10-year difference by the time you get towards the end of the route. And London is not unique. I don't have your data at hand, you'll know that far better than I, but inequalities in health are a persistent scar on our societies and a persistent challenge to our health and care system. So another reason why fundamental change is needed. And this diagram, often used in this context and used in one of the King's Fund reports from Dahlgren and Whitehead, really reminding us about the wider determinants of health and well-being. Of course, healthcare is only one consideration when it comes to addressing that changing burden of disease. This is a diagram which at a high level sets out the thinking that we developed at the King's Fund on the shifts that are taking place and that need to take place. And you'll see individuals towards the bottom, populations at the top, and then the focus of intervention, both care services and health improvement. And just for the avoidance of doubt, all of these quadrants are important and have a continuing contribution to make, so that when we or family members become ill, we need care and support. We hope we get quick access to high quality care. It might be the general practitioner, family physician, it might be in the ED in the local hospital. But for some time, certainly within the National Health Service, we've been trying to do more than that by making every contact count. So seeing opportunities when I turn up to see my GP, to check on my screening, to check my blood pressure, to build in those preventative opportunities through the care service. But the biggest prizes are towards the top here. And it goes back to the global burden of disease, because if we're going to address the challenges around morbidity and disability and frailty, we need a health and care system that really is coordinated and joined up, recognising that the intense users of our services will often have 3, 4 or 5 needs and healthcare conditions. The rationale for integrated care, but also leading into the rationale for prevention and a focus on population health. And that's the big prize on offer. If we can make these shifts, recognising all 4 quadrants matter, then we'll be able to reuse and redesign and repurpose the staff, the resources we have around the problems of today and tomorrow. A recent report from the King's Fund on a vision for population health towards a healthier future. This document, written by David Buck and colleagues, unpacks this a little bit more and talks about these 4 pillars of a population health system. So starting with the integrated health and care system, and obviously talking here about secondary, tertiary prevention, among other contributions to make. But the wider determinants of health and well-being, which I'll talk more about in a minute, our own decisions, our own lifestyles and behaviours have an impact, and places and communities, something that we feel is more and more getting attention, and quite rightly so. And all of those pillars needing to work in tandem with each other if we're going to address the health challenges I've been describing. Here are some more specific, if you like, reports about that fundamental shift in transforming health and care. I opened up the Global Mail this morning and saw an article about the Australian Royal Commission on Ageing in that country, and the author making the point that the challenges in Australia are very similar to those in Canada, and I have to say from my reading of the article, exactly the same as the ones we have back home. We are not doing sufficient to adjust to the needs of an ageing population, and that applies for us far more, I would say, in relation to social care and supporting people in their own homes or in residential care, as it does in relation to what the health and medical care system does. And this report, written by David Oliver, who's a practicing specialist in the care of older people, and other colleagues, sets out what good looks like. So if you recognise that need to change, where should we go to see examples of better care to make our services fit for an ageing population? The report on reimagining community services is about what goes on in general practices and the wider community services that people look to if they don't require specialist support from hospitals. And I'll give an example of that in a moment. The population health systems, well, I've touched on that already around the reframing of the debate. But let me say a little bit about the report on specialists in out-of-hospital settings. This is a report the King's Fund published about 4 or 5 years ago now. And it came out of the curiosity that we had as to why in our system is there this stark divide between family medicine that takes place in the community around primary care teams and specialist medicine, which takes place almost universally with a few exceptions in hospitals. And of course there are historical reasons that at the time may have made sense but really don't make sense at all today. But there are some positive deviants in the medical profession back home, positive deviants in relation to specialist care, who've said, well, the future isn't just in the hospital, it's about how we work across hospital and community. And we found 6 examples of these positive deviants. One in relation to caring for older people, another caring for children, and examples in relation to dermatology, diabetes, respiratory medicine, and one other which I can't remember. And these were specialists working in hospitals in different regions who saw the opportunity of going beyond the walls of the hospital with the nurses, the AHPs and the other team members, and supporting the family doctors and their teams to do far more of the routine care, making it possible for only those patients with more complex needs to be referred into hospital. So Partha Carr, he is a diabetologist in Hampshire, and he does this in relation to his services. Most of their work now is about training and skilling up the primary healthcare teams to do even more of the routine care of people with diabetes, and only the most complex patients are seen within the hospital setting. Eileen Burns, who's a specialist in the care of older people, who practices in Leeds in Yorkshire, similarly with her team from the hospital, works in the care homes, the residential homes, supports the general practices around their understanding and knowledge and skills in caring for the growing number of older people who represent a huge part of the workload of general practices, and also, of course, the workload of care homes and nursing homes. A wonderful example of a paediatric service in West London, similarly, where patients can go to community hubs. The specialists from the local teaching hospital, the Imperial Foundation Trust, meet with patients and family members, but also with the general practitioners with whom those patients are registered. And there's a co-consultation model. And all of these different examples are what I would describe as population-oriented specialist care. They're relatively unusual still back in the NHS, but they've arisen out of the initiative of the specialists themselves saying, this is the model of care we think is fit for the future, rather than that stark divide between generalist care and specialist care that was established many, many years ago. And that illustrates one of the transformations in care that we argued back in 2012 was needed to reorient our healthcare service. And I do want to say a little bit more then about the role of acute general hospitals, including teaching hospitals, within future models of care, because they are so prestigious, they are so successful in attracting more resources and more staff to deliver the work that they do. They are the powerful, prestigious players within the healthcare system. But the point of this report, again, was to look at examples where change is afoot. And simply, we suggested there were 3 scenarios, at least here. Traditionally, hospitals have really been islands or fortresses, almost putting up the barriers to wider communication and engagement, wanting to build up their resources, their expertise, focus on the treatment of patients with acute conditions through using the specialist care that's available to them. And that might have been the case 20 or 30 years ago, as that might have been the right answer 20 or 30 years ago, but no longer today. So the second scenario is around what's their role within integrated care systems. And the examples I've just given illustrate what that might mean. But the third scenario plays into the topic of today, the role of acute hospitals within emerging population health systems and how they might contribute to improving health and well-being. I've said already, but I want to repeat, clearly some of that is about secondary and perhaps tertiary prevention. I take that as a given. And that's why I don't want to speak much more about it today. We all understand what that looks like. But there are other contributions that acute hospitals can play within emerging population health systems, which are less obvious until quite recently, and that's what I want to try and focus on in the time I have. But before I do, I'm not just talking about acute hospitals, I'm talking about primary care and community services as well. And Bromley by Bow is a good example of where some of this work is already taking place. This is a small group of general practices in the East End of London, serving a diverse and quite deprived population, led by Sam Everington, one of our best known general practitioners, who with colleagues has developed a much more holistic model of general practice and primary health care. Because in this community, Sam and the other staff delivering care recognised quite early on that the patients they were serving, the ones who are registered, 26,000 patients with the Bromley-by-Bow Health Centre, didn't just have medical and nursing needs. They had much wider needs when they arrived at the surgery, and needs which could be met in other ways. So what we now are beginning to call social prescribing within the National Health Service, I don't know if that's a phrase that's in currency here as well. Yep. They were pioneers in the delivery of social prescribing within the Bromley-by-Bow model. By the way, it's not a phrase I like. I think it's medicalising what shouldn't be medicalised, but let's have that debate later on. So in Bromley-by-Bow, of course, you'll get to see the GP and the nurse and other clinicians as well, if that's appropriate. But they try and meet the needs of their patients in a variety of other ways. They offer nutritional advice and cookery classes. They offer yoga. They offer art classes. They offer a host of complementary therapies, if you want to use that language, because of the experience they've had around the patient population they serve. It's incredibly diverse in that part of East London. I think last time I heard Sam talk about it, he said their patients speak 30 different languages. So having translators at hand is a very important part of what they need, as well as the health and care expertise. And it provides a glimpse of the sort of future, if we think about community-oriented primary care, how we make use of all of the assets, not just the narrow definition of the primary medical care team. Here's another of my favourite examples of reimagining our community assets. This is led by a local government authority in the northwest of England, a Wigan council. It serves a population of about 1/3 of a million. And it's led a transformation, a true transformation in how public services are delivered to that population. Because the philosophy in Wigan is that the council, the NHS organisation, should work with people in their community, not do things to them. So it's about turning things around and thinking much more about what that means in practice. The council hired an anthropologist. I think it's probably still the only council in England that saw a need to hire an anthropologist. And what he did was to say, we need to understand the population we're serving here, these 330,000 people. And the best way of doing that is to go out and meet people and talk to them. There's an original thought. And what he did was to train the people who were employed by the council, whether they were frontline professionals or back office administrative staff, and trained them to have what they call different conversations. Going out to where people work, where people play, where people live, with an open mind, that's the language they use, and understand what matters to people in Wigan. What are their concerns? Not presuming, as a council, they know the answer to that, but being much more receptive to hearing people's views. In this example, because we've been through a period of austerity in public services, Wigan, like every local authority, has had to make deep cuts in its public spending. So about 1/3 of the budget it spent back in 2010 has disappeared because of these cuts that governments have felt they needed to make. But Wigan said, if we're going to make cuts, we have to be bold and radical, not by incremental changes here and there. So what they chose to do was to set aside some funding to invest more money in voluntary sector community organisations, because there is a vibrant set of those organisations in Wigan which were able to find better ways of meeting people's needs than those that had historically been funded by the council. And to give you a concrete example of that, the council closed almost all of the day centres it had funded up until then. These are places where Older people, often living on their own, were bussed in to have some time together during the day and then bussed back home at the end of the day. And the council realised it was spending quite a lot of money, and the evidence suggested that they weren't really delivering a great deal of benefit. People were sitting in a day centre in a similar way they were sitting at home without really getting the benefits of being with other people needing that kind of care and support. But when they closed the day centres, which was controversial, they used the extra funding for their community organisations to provide much more cost-effective alternatives, befriending people, bringing in volunteers, finding out what mattered to the people who had been attending those day centres, and then giving them access to the kind of support that would be beneficial to them. There's a case study about the healthier Wigan partnership you can access. The point about this example for me is they've also got the data about how population health in Wigan has improved during this period of cuts and austerity, and has improved more rapidly than in similar areas with broadly the same demographics as the population of Wigan. Kate Ardern is the Director of Public Health, and she's one of the leaders in this system who's been instrumental in this transformation of care within the community. And it's been about this mobilisation of all of the assets in civil society as well as in the public services to enable Wigan to cope with austerity and cuts and to improve health outcomes. A lot of people say it can't be done, but Wigan shows it has been done and it's real. And I can tell you because I've visited on more than one occasion. I want to move on now to, again, I don't know if the language of anchor institutions is one that's familiar to colleagues in the room. It comes out of the Democracy Collaborative in the States, being picked up by a sister foundation to the King's Fund called the Health Foundation. And this report sets out the case for the NHS to understand what anchor institutions are and the role they might play. Essentially, they are usually large public sector or not-for-profit organisations, of which universities are a great example, of which hospitals are a great example. Institutions which are embedded in their communities, which have made an investment of buildings and staff in those communities, which would be very difficult to relocate elsewhere. So have huge potential to use their economic leverage and power to work with people in their communities. In this case, I'm talking about improving population health. And one of the earliest adopters was Nhs Hopkins, and you can find lots of information about what Nhs Hospitals did when it decided to become an anchor institution. This report gives examples, a few examples, not many because there are only a few examples, from where the NHS is picking up these ideas. And you'll see this figure drawn from the report spells it out in a little more detail. So these institutions are very significant employers in the communities where they are based. And some NHS organisations now are recognising that through their training, through their apprenticeship schemes, through pathways into work. For example, earmarking a proportion of new appointments for people who are drawn from the local area around where these anchor institutions are based. Or putting in place training and apprenticeship schemes to help people who may be coming from relatively deprived backgrounds to go through skills training as an entry point into what could become for them good, high quality, well-paid jobs in relation to the environment in which people live. Another example here, purchasing more locally and for social benefit. So the purchasing power, the procurement of goods and services, whatever they might be, is a significant contribution of anchor institutions. The organisations in the NHS have analysed where they source their goods and services from, often find there is substantial leakage outside the immediate area, often of the order of 70 to 80%. as long as they're not breaking the rules around procurement, there are opportunities for bringing back some of that resource into their local community. Applying a test of social value, not just of economic value in so doing. And that notion of social value is more and more under discussion. Using buildings and spaces to support communities. Let me give you an example from my own experience on the board of the Royal Free Hospitals in London. We are investing through our charitable arm in the development of affordable housing for staff who work in the hospitals. London's a very expensive place to live. The pay that our nurses and AHPs and others receive, and some of our junior doctors, is not sufficient for them to be able to work and live in the same area. But as an anchor institution, we have some economic leverage to do something about that and to use our resources to provide access to affordable housing. It makes sense because it helps us with the workforce challenges we're faced with. And then working more closely with partners. Top right, I'll say a little bit more about that. That's where our integrated care systems, like your Ontario health teams, have an important role to play. And then finally, reducing the environmental impact of the NHS. And this is the example I want to use to illustrate this. From Newcastle on Tyne, up in the northeast of England, the first NHS hospital to make a declaration around climate emergency, make a commitment to zero emissions, was up in Newcastle on Tyne in June this year. So this is still relatively new for this. There are a few other places are beginning to do the same. The leadership here didn't come from the NHS, it came from the City Council and it came from the university, who are working with the NHS in what you might call an anchor collaborative, not just an anchor institution. And jointly they signed a declaration with another university, there are two in Newcastle, to show their commitment to taking these issues seriously. There are lots of things going on. The NHS Hospital is run by Dame Jackie Daniel. It's a large teaching hospital. It serves the whole of the northeast of England. It's now made a commitment to zero emissions by 2040, which is 10 years earlier than our government commitment across the country as a whole. They're doing this through lots of little things rather than one big breakthrough initiative. So using electric vehicles for transporting staff and patients and other things around the hospital sites. A major commitment to recycling, and also zero waste to landfill is another example of what they're doing. The Trust produces electricity itself to cover some of its energy needs, and the rest it buys from the producers of renewable energy. And within the organisation, within the hospital, 300 people, 300 staff have been identified as green champions to support recycling, but also to reduce the use of single-use plastics and other things that contribute towards the target of zero emissions by 2040. So another example, because as the Lancet, I think, reported some time ago, arguably global warming, climate change is the biggest threat to population health that we have across the world. So let me try finally to bring a few of these bits and pieces together. My own thinking on this, and shaped very much in discussion with my colleagues at the King's Fund, it comes back to 3 Ps. 1 P is partnership working. And I'll say a little bit more about that in a second. But the other 2 are the ones represented here, focusing on population health and doing so in place-based systems of care. And more, the focus in England is around place, defined as a city, defined perhaps as a county, or in some cases defined as a region, where organisations are coming together, trying to work over and above their organisational responsibilities in partnership with this focus on population health and well-being. And of course, organisations still have a continuing role, but increasingly the organisations are taking a back seat as the partnerships, the places and the populations are taking more of a front seat. And none more so than within the integrated care systems that have been now in existence for about 3 years within England. There are 40 of these systems. We have a population of about 55 million, so you can do the math around the average population size. They have no legal status. They are what I call a coalition of the willing. And the willing, if they are, and sometimes they're not, the willing are the NHS organisations across hospitals, community, mental health, primary care. The councils, as in Wigan, who can use their public resources as anchor institutions. The voluntary sector organisations and others like universities as well. Coming together in informal, not legal partnerships to look at how they use all the resources, the public resources and sometimes the private resources, to improve the health and well-being of the places and the populations they serve. And although there was a lot of skepticism about these systems to begin with because they had no legal status, they had no formal power, the resources and the decisions are still taken at the organisational level, not at the system level, actually they are beginning to get some leverage and traction. And in Coventry and Warwickshire, the one that I have the chairing leadership responsibility for, we are in the middle of a year of health and well-being, announced not by the NHS but by Coventry City Council and Warwickshire County Council. Coventry has declared itself to be a Marmot city, a very explicit commitment to recognising, wanting to tackle and reduce health inequalities in its population. And it's showing the way for the NHS authorities, and particularly the hospitals, on what needs to be done to refocus upstream and to begin that transformation of health and care that I've alluded to already. And in thinking about this, we're back to some extent here to the insights of Nobel Prize winning economist Elinor Ostrom and her work on how we govern the commons, because the resources available to healthcare are finite, and if we misuse those resources and spend them in the wrong direction, then we're not getting the benefit that our population would expect of us. And integrated care systems are, if you like, one way of how collectively organisations can come together in partnership to try and manage the commons and to avoid the tragedy of the commons that Garrett Hardin wrote about back in 1968. I'm enthusiastic, I hope you gather that, but I'm not naive either. These systems are still young, they're still immature, they're nascent, they're fragile. Who knows, I could come back in 6 months' time and tell you how poorly they are now doing, because this is all about willing partnership rather than using other levers. Let me end by, and I always like to bring in some recommendations from my own personal reading around these issues, the intellectual underpinnings. Particularly, I would say what Atul Gawande has written about this being the century of the system and needing system responses to climate change and to changes in health and care, and the work of Peter Senge and colleagues who've written about this being the dawn of system leadership, not just organisational leadership. But especially, I wanted to recommend to you, if anybody's read Kate Raworth's book on donut economics. I bear no brief for Kate, I don't receive any of her royalties. I sincerely recommend her book to you as a very thoughtful assessment which has a bearing on the issues that I've been describing. What is the donut here? Well, the donut is the picture you see. And what she's saying is this sweet spot is the donut itself. Beyond the sweet spot on the outside is the prospect of environmental catastrophe if we don't sustain the planet and do what Newcastle and many other places are now beginning to do. And in the middle of the donut, where there's fresh air, is where there is simply deprivation as a result of poverty and the inability of our societies to give everybody the means they need to live a reasonable life. And what she's arguing for is what some people would call inclusive growth. Growth that is not growth for its own sake, but also is equitable growth, where everybody has a fair share, where there's a distribution that benefits the many and not just the few, but also addresses that big challenge around climate change. And she goes into much more detail than I can in the time available here, but the thinking that Kate sets out is very much in line with a few of the themes that I've tried to develop today. So I hope you'll take a look at what she said and the arguments that she's put forward. So thank you very much again for inviting me. I hope that makes sense, and I hope those sort of perhaps counterintuitive ideas in some ways go some way towards explaining how health systems can indeed contribute to improving population health.